Live from the Bob Levy Broadcast Center overlooking the Toms River, it's time to get up, get out, do something. Wake up with Jeremy Grunin. Be a part of the show, 732-505-1160. News Talk Radio WOBM AM 1160 and 1310. Listen online at WOBMAM.com.
Hey, welcome back. Wake up with Jeremy Grunin, 7:06 Wednesday, August 3rd, 66 degrees. Get up to 77 today. WOBM AM 1160 and 1310. News Talk Radio, streaming live on the Radio Pop app and WOBMAM.com. 732-505-1160 to join the conversation. We are now joined in studio by Dr. Vladimir Klinov, neurologist at Southern Ocean Medical Center. Good morning, doctor. How are you?
Good morning. How are you today?
I am fantastic. So we are talking about neurological conditions like epilepsy, migraines, numbness, et cetera, which goes perfectly in hand with the folks at Health South who we just spoke to who are dealing with their stroke programs. But why don't you tell me first a little bit about your background and training?
Well, it's kind of interesting because prior to my medical career, Jeremy, I was a chiropractor. I was practicing for a couple of years and realized that my hands are tied and that I cannot offer to the patient what I should. And I decided to go into the medical school, finish medical school, went to the neurology residency here at Cooper College in New Jersey. And then during my neurology residency, developed special interest in epilepsy. And I did my epilepsy fellowship at University of Pennsylvania.
Oh, nice. All right. Well, listen, can't argue with UPenn on that one. Like going Ivy League. So how do you remember how you first decided to get into chiropractic? I mean, what was the motivation there?
That's actually also interesting because prior to being a chiropractor, I was a massage therapist. So
really?
I always liked neuromusculoskeletal condition. So it's developed from massage therapy. I went to the chiropractic school. It wasn't enough, so I went to the medical field.
Oh, so you really worked your way. You really worked your way up the body food chain there.
That's true.
So now, if you wanted to, you could be a massage therapist who could prescribe medicine.
Well, sounds good.
That would
I'll
be
try.
Yeah, that's a whole different thing. That's for a whole different show. So we understand. Obviously, you mentioned that you're especially interested in epilepsy. What is it that really made that? How did you get into that specialty? What is it about epilepsy that intrigued you?
It's one of the neurological conditions that I can change people's life. Epilepsy is like disabling condition, and it's difficult to treat. But a patient who has epilepsy, as you probably know, they can drive. They can work. They have anxiety to go outside. They have fear of having seizures. So, I love to help people and actually treat them with this condition to change their life.
But not everyone. So let me see if I get this right. Everyone that has epilepsy, is it true or false? Everyone that has epilepsy has seizures.
This is true. But not everyone who has seizures.
That's right. You totally took my punchline. I was going to say, does everyone who has seizures have epilepsy? So how do I know the difference?
Well, there's two different. We have differentiation. There's provoked or unprovoked seizure. There's different cause for seizures, and usually people who have like multiple seizures, at least 2 seizures, might be diagnosed with epilepsy. But approximately 10% of population might have 1 seizure in their lifetime.
Really?
It doesn't mean that they have epilepsy. Because there's different causes to have a seizure. It might be electrical imbalance, alcohol withdrawal cause seizure, using drug can cause seizure. So it doesn't mean that these specific people, they have epilepsy.
Gotcha. So there are different types of seizures also, right?
That's correct.
So what are the different types of seizures?
Well, we're going to the radiophysiology and etiology of seizure. That's interesting. Okay, so I like to educate my patients.
Oh, good. All right. so drop some knowledge on me, Doc. Come on.
Okay, so there's generalized seizure.
Okay.
And there's like what we used to call partial complex seizure. So it depends what part of the brain is involved. In generalized seizure, how I explain to my patients that at the same time the whole brain is involved right away. In the partial seizure, what we have, it's just one part of the brain involved, and then there's a provocation. It goes into another one,
right.
And it may become generalized. This is the most common type of seizures.
Gotcha. All right, and then there's so what's an absence seizure?
It's also absence seizure. It's the term actually reserved for pediatric population.
Oh, okay.
Because this is one of the form of generalized seizure. Sometimes adult population come with me and complain about absent seizure, we're diagnosed with absent seizure, which is not really correct. It's just the seizure, what we call complex partial seizure, with the symptoms of absent seizure.
So how do I? So let me get this straight. How would I know? A lot of seizures also can happen at night, right, while somebody's sleeping.
That's correct.
Right. So how would I know? What would be some of the symptoms that when I wake up in the morning that I realize that I had a small seizure, that something went wrong? Like, is there a way to tell?
Most of the time.
Yeah.
Not always, though. Not always. First of all, if you have your partner, significant other, they can tell you whether you had a seizure or not. Because some seizures have, as you probably heard about, convulsion, and you can wake up your partner and they can tell that you had a seizure. If you don't have patients usually complain about when they woke up, they may wake up on the floor. They may wake up with a sore muscle or bit their tongue, bleeding from their mouth. So this kind of symptoms tells me that, that something happened overnight.
Right.
And then I do workup and diagnosis and see what we're dealing with.
Right. They also, and unfortunately, I'm sorry to say, I've had a lot of experience with this in the not so distant past. I assume they could also wake up disoriented, just kind of not in full, maybe not even in full control of their faculties. First thing, that something has gone wrong overnight that has kind of caused their system to kind of not reboot correctly. Can that also happen?
That's correct. And it depends on the time frame. If seizure happen, let's say in the beginning of the night, then they can wake up perfectly normal, just with the pain, soreness. If it happened recently, within an hour prior to the awakening, so it might have disorientation, confusion. You're absolutely correct.
Well, let me ask you this now. What about sleep apnea? Right. So can sleep apnea, because sleep apnea seems to me like it's a term that has kind of become vogue over the last, I want to say 15 or 20 years, right? Because before that, you just snored, right? Or you had a really bad snoring problem, all right? You sounded like you stopped breathing in the middle of the night, and nobody really thought much about it other than they wanted to be in a different room or a different part of the house, right? But sleep apnea could be a precursor, to other kind of brain issues, correct?
Well, that's correct. It could be precursors. There's a higher percentage of people with a sleep apnea who might have a seizure.
Right.
But there's no straight relationship between sleep apnea and a seizure.
Right. But it is something that, it's not just a matter of snoring in the middle of the night. It's something you should probably get checked out because you don't know where that's going to go, right?
That's correct.
All right, cool. So who is most at risk for seizures? I mean, what population?
Well, epilepsy has bimodal distribution, what we call. Seizure starts in the childhood, and also seizure starts in elderly population. Because predisposition, and especially in elderly population, are strokes, brain trauma, any intracranial lesions may cause seizure and interrupt electrical activity of the brain.
Gotcha. And does that cause long-term problems? I mean, when someone has a seizure, I mean, is it just a one-time event and one and done and it's over, or what happens?
Absolutely. Well, let me tell you, as you probably know, that seizure is abnormal electrical activity of the brain. And when that happens, it's uncontrolled electrical activity of the brain. And when it happens over and over and over, it causes permanent damage to your brain tissue. And most common complaint, because most seizure, about 80% of all seizure come from our what we call temporal lobe. Right. It's two lobe of the brain on the lateral side. So they come from the temporal lobe, which is responsible for memory.
Gotcha.
Most of them. So memory loss is the most common complaint.
Gotcha. When we come back, we're with Dr. Vladimir Klinov, a neurologist at Southern Ocean Medical Center. I want to talk about treatment options, and I also want to kind of get into headaches and migraines versus regular headaches and that kind of thing. We'll be back more Wake Up with Jeremy Grunin right after this.
Everything you need to know about the Jersey Shore. This is Wake Up with Jeremy Grunin. News Talk Radio, WOBM AM 1160 and 1310.
Hey, welcome back. Wake Up with Jeremy Grunin. We are here with Dr. Vladimir Klinov, a neurologist, Southern Ocean Medical Center. So, Doc, what kind of treatment options for seizures? What can we do? How do we stop this? What do we do?
How do we stop? Okay. So there's multiple treatment options available, especially now. First of all, we start patient on medication. And in more than 50% of the cases, we will be able to well-controlled seizures with just medication. If it doesn't work, we can offer next step. We have what we call vagus nerve stimulator. It's an implantable device. It's been on the market for a long period of time, and patients have very good results with that as well. And recently in the past couple of years, what we have responsive neurostimulator. So we do the workup for the epilepsy patient. We found the epileptogenic focus in the brain, and neurosurgeon actually implant the device with the wires inserted into the brain tissue, and actually we teach that device to recognize the seizure and treat it prior to the spread of the seizure into the other brain area.
That's pretty cool.
Yeah, and of course, then the last options on the list, but so far this is the best options for the seizure freedom is the surgery.
Right. All right. So let's move along to some of the other problems that you deal with. So, and you deal a lot with headaches, right? So at what point does it stop just being an annoying headache, and should somebody come in and talk to a doctor?
Oh well, we have it. I teach my patients. I actually educate my patient about danger signs. So let's say if you have developed a new headache, you never had a headadache before, and you develop a new headache, probably it's a reason for evaluation. When you have a systemic symptoms such as fever, let's say weight loss, headache during the pregnancy, or headache in immunocompromised patients, I think it's reasonable, very reasonable to see the neurologist.
Right.
Also, if you have with a headache, you develop neurological symptoms such as vision loss, altered mental status, or seizure, as we discussed previously. It's also probably good.
Right.
To
so you're saying if I got a headache and I can't see anymore, I should probably probably check out a doctor.
Yeah, probably. Yeah. And also the most I'm trying to educate also the population and all the people, all my patients, about what we call thunderclap headache, which is excruciating headache, the worst headache in their life that they develop absolutely suddenly. Okay, I don't want them to wait. I don't want to take the medication. They should go to the emergency room immediately.
Right. So, and what's the difference? How do you classify a headache versus a migraine?
Well, migraine is a headache.
Right.
Headache has multiple. There's multiple types of headache. Migraine is one of them, and migraine is the most common headache that I have my patient seeing me for. And headache usually it's stereotype headache. The headache that happens almost identical over and over and over. People complain of excruciating pain. They disable for 28 to 48 hours.
Ooh.
They cannot work. They have to be in quiet, dark room. They might have photosensitivity, sensitivity to light.
Yeah.
I have nausea, vomiting. So all the symptoms, actually, history gives me the best diagnosis. Probably you know, Jeremy, that 80% of all diagnoses come from the history.
Yeah.
And then we do the test just to support or rule out some conditions.
Okay, very good. And so what do you do? What do you do when somebody's got migraines? What do you give them? You just say, here, take these 2 Advils and come back in 2 weeks. Let me know how it is.
Well, there's few medication. There's many medication for migraine. Actually, there's medication that stop headache, and there's also, if you have a frequent migraine, we can offer what we call preventative treatment for this medication. That medication that you take on a daily basis, and it's and this medication, as we choose them based on depend on each patient.
Right.
It's completely case dependent.
Right. Gotcha. All right. So, and I know the other things that I wanted to kind of talk about, I know you deal with numbness and tingling, and you also deal with MS. So I want to talk a little bit about that when we get back. I also want to give you your magic wand and give you your opportunity to change the world. I know you've been itching for that probably for a long time now. Let's be honest. So we'll do all that after the break. Dr. Vladimir Klinov, neurologist, Southern Ocean Medical Center. He and I are going to listen to Kevin Williams' Hometown View. Then we're going to listen to the news. Then we're going to chat some more. Wake Up with Jeremy Grunin. Back after this.
The news never stops at WOBMAM.com. Get the latest from WOBM News, the Town Square, New Jersey News Network, and Fox News Radio. Wake Up with Jeremy Grunin. News Talk Radio, WOBM AM 1160 and 1310. Live from Town Square Towers at the heart of the Jersey Shore. Wake up with Jeremy Grunin. Get up, get out, do something. Join the conversation. 732-505-1160. News Talk Radio WOBM AM 1160 and 1310. Listen online at WOBMAM.com.
Hey, welcome back. Wake up with Jeremy Grunin. We are here with Dr. Vladimir Klinov, neurologist, Southern Ocean Medical Center. We're talking about, neurological stuff. Doc, we were talking a little bit about one of the other reasons people come see you might be for numbness or tingling. What could that be from?
Well, Jeremy, it's an extremely broad field.
I know.
And my approach to numbness and tingling, how I see the patient, it's the time frame. Because sometimes it could be worrisome sign when patients started to complain. It could be just chronic condition. So from my point, first question that I ask, when did it start?
Right.
Whether it's recent, sudden onset of numbness, tingling, or is it been there for a long period of time? So some of the examples of the sudden onset of numbness, tingling, weakness could be stroke, as we're all aware of that, right? Other condition could be, if it's a chronic condition, could be malabsorption, some diabetic neuropathy, what we call a problem with the kidney, thyroid, so et cetera, including like sometimes infectious may cause numbness and tingling, such as Lyme disease, right? Or autoimmune disorder. We're not going to go list them all because it's going to take whole time.
Right.
So that's how I approach it. The time frame is very important.
Gotcha. Talk to me about multiple sclerosis. What is that?
Oh, well, it's another extremely big field in neurology. Probably, as you heard, this is the most common immune-mediated inflammatory demyelinating disease of central nervous system that neurologists that we're dealing with. And actually, there's two theories what causes multiple sclerosis. We still don't know exact etiology of that, whether it's autoimmune, when you had some type of virus and your body developed antibody and attacking your nervous system, or whether it's some residual virus in your body still attacking your nervous system. There's this two theory about multiple sclerosis.
Gotcha. And is there a specific age that that people are more at risk to get that?
Yes, typically, it's a young female. It's a classical case of multiple sclerosis, but there's a female to male ratio approximately 2-to-1.
Gotcha.
And the mean age of onset about 28 years old. But
gotcha.
People were diagnosed at 15 and at 45.
Right. And symptoms, what does that look like? What kind of symptoms would present?
There's no unique symptoms to multiple sclerosis. It could be depends what area of the brain involved. It could be numbness and tingling, as we discussed before. It could be weakness, could be stiffness, could be balance problem, could be bladder problem. It's extremely broad symptom list.
Cool. We're about to give you your magic wand, right? Your pixie dust, your fairy dust, your ability to kind of make an impact on the world, Doc. But before we do that, I have to know the accent. Southern Ocean County, or is that Southern Jersey? Where's that accent from? I can't place it exactly.
Well, originally it's Russian accent.
Oh, it is Russian. Okay.
Yes.
I wasn't sure. I thought possibly Cherry Hill area, somewhere around there, or Mount Laurel. But no, it's Russia. Okay. Just wasn't sure. For our listeners, I wanted to clear that up. And no, I already asked about the emails. He has no idea. Let's move right along. So I'm giving you we're giving you the magic wand, the pixie dust, the fairy dust, the ability to make an impact. Dr. Vladimir Klinov, neurologist, Southern Ocean Medical Center. What are you doing if you could just wave your wand around and make something happen?
I would probably ask not to self-diagnose my patient, because many patients have a tendency to self-diagnose themselves and occasionally to develop like self-treatment based on a web. They search the condition and then they said, well, this is going to help me. If I would eliminate that, I would be the happiest person probably.
Yeah. So you're saying that I can't take care of my maladies just by going on WebMD?
Probably not.
No?
Come to see me.
All right. Well, I'm just saying, I mean, I think that there's so many resources on the internet. I mean,
absolutely.
Listen, you could just... I think I think if you are a hypochondriac in today's society, you can make sure that you have any disease in the world just by going online and figuring it out, because it can really start to make your head spin after a while.
I agree with you on that.
Cool. All right. So where would folks learn more? Is there like if they wanted to come see you, if they wanted to learn more, what could they do, Doctor? Can they reach out to you somehow?
Absolutely. They can call Southern Regional Medical Center Neurology Department and schedule an appointment.
Okay, perfect. So that's really great. So we are Dr. Vladimir Klinov. He is the neurologist at Southern Ocean Medical Center. Doctor, I'm sorry, I'm coughing a little bit. I'm a little verklempt. Doctor, thank you so much for spending some time with us today, and and really kind of opening our eyes to some of the possible symptoms and possible issues that can be inflicted upon us neurologically out there. So thank you so much for your time this morning.
Thank you. It was a
and
pleasure.
we'll be back with more as I choke. Wake Up with Jeremy Grunin right after this.